we have the next presentation by Dr. Sanjiv Gupta at the moment. And I'll just do a small introduction. Dr. Sanjiv Gupta is from HDM Hospital, Jaipur. He has experience of over 32 years of expertise in the field of interventional cardiology. He has been contributing to handling various complex interventional procedures, and he is known for his attention to accurate diagnosis and treating patients empathetically. He has also participated in various research work and various workshops under the cardiology department, and has published various papers in renowned national and international journals. Handing over to Dr. Sanjay.
Thank you very much for the introduction. Good evening, chairpersons, moderators, and participants. My topic is Taming the Rock, successful PCI of a severely calcified RCA post-CABG. So this is a 77-year-old male diagnosed to have triple vessel disease in 2019, medically managed CABG in 2021 with a lima to the LAD and a venous graft to the OM. The RCA at that time was perceived as unsuitable for grafting because of and was not grafted. Patient continued to have angina and had check angios and a CT angio, which showed that the grafts were working, but the RCA was atheromatous and was deemed unsuitable for PTCA high-risk procedures. Continued rest angina came to our attention in 2025, needing multiple episodes of sorbitol for relief, and ECG showed infralateral changes with dynamic ST2 movement during pain episodes. Ejection fraction was conserved with moderate MR. TNI went up during these acute episodes that he was hospitalized. His diabetes was fairly well controlled.
Is it just me, or could the audio be improved?
You can't hear, sir?
Yes, I can reasonably hear him, but maybe that's some of your lines. I could hear him reasonably well, but
sir, I have switched off the background AC. Are you able to hear me better?
Now better.
Yes.
So I'll proceed from where I left.
I think you're okay. Your slides are visible. So
actually, your slides are up till now. I think we are all okay.
Okay. Yeah, go ahead.
So we need to see the images now, but yeah, we would like to hear what you're saying also.
So he had some degree of renal dysfunction, no baseline anemia. These are the angios which are seen from 2019, 2021. He had the bypass. This is a graft in 2023 and 25. That is the venous graft to the OM, which is functional. This is the disease in the LAD for which he received lima to the LAD. And this is the status of the graft again in 2012. It is working. This is the scenario of the RCA over the years. As you can see, there is the Stram-Tack appearance. It's a highly calcified, severely atheromatous RCA, lesions extending from the ostium, critical lesion here, diffuse disease here. The PLV is diseased. And this was not grafted, as I said, at the time of the CABG. In 2025, the scenario has become even more critical. This is absolutely a thin line. It was told that this is a marble line and anything done could cause the perforation. And of course, there's multiple lesions, tight lesion here. And the venous grafts, as I showed, were working. And the lima to the LAD was also working. So basically, post-CABG, diabetes, functional grafts, severely symptomatic, multiple episodes of angina at rest needing sorbitol, single vessel disease. What to do for this patient? He had visited multiple places, and ultimately he had been explained that high-risk PCI could be done. He was willing for the expense, and a multiple combination of tools that are listed here were done with mechanical support. By a femoral approach, a TPI was placed because I expected that there will be a lot of thrombotic burden, and some tool of imaging was hoped that we would be able to do. So femoral approach, 7 French, AL1, IBP prophylactic drill on left side, all punches were ultrasound guided, arterial punches were closed with Proclide, Visipec in view of age and raised creatinine. Imaging episode was IPUS, and standby drugs and standby support catheters were kept online. IBP introduced, a TPI put. I thought that an IBP is needed despite LV function because I expected a lot of no reflow because we are going to be ablating from top to bottom. And I put in a TPI prophylactically in case there's an arrhythmia that we should be able to manage it. This is a Siam wire put across with an IVUS. It would not cross the most critical point of lesion. And so we just took a pullback from this point back to the ostium, which is on display. As you can see, it's diffusely calcified. There is nodules. It is dense calcium. It is areas are completely covered with more than 370 to with more than 270 degrees. Here, this is nodule. So it was not a straightforward problem. The Sion wire was exchanged for a Viper through a microcatheter, and we started the orbital initially with 80,000 RPM. 9 runs were done in total with the usual 30 plus 30 protocol. And check angios were done at each stage to see if there is no reflow. So you can see that there is flow, but the flow is going down, and after there was some degree of slow flow. So thereafter, since the result was incomplete, we said the artery size is correct and we should do more debulking. And we proceeded with 120,000 high revolution, total of 9 runs. 6 runs in the proximal to mid segment for 30 seconds, and the distal runs were forced to be kept short because of what you will see. So here you can see here that there is some no reflow occurring. So the device was pulled back, intracoronary drugs were given to facilitate the flow, and once flow was re-established, again burring was done. When we reached the 3rd segment, there was a very loud noise here. This was associated with severe ST elevations. And ultimately, at this point of time, there was total occlusion or no reflow. The STs went up. The patient had angina, had bradycardia. Unfortunately, as you can see, the TPI got displaced at some point before, but we were so busy burring that we didn't notice this. Some degree of CPR was to be done. Intracoronary drugs were given. Rhythm was restored. The patient was conscious. And at this point, I decided that we'll just intubate this patient because we need more work to be done and we can't afford this problem again. Once the TPI was repositioned, there is still no reflow going on. And finally, after a lot of effort with intracoronary drugs and some balloon inflation, we were able to get the rhythm back. As you can see, there's... Excuse me? Excuse me? So, no, we didn't lose him.
Dr. Gupta, my recommendation, if you just switch off your video, you may be able to, because you are intermittently going away. So, I mean, it's interesting to see what you did later on, because just switch off your video, you'll be able to convey, because you're missing your internet, probably is not allowing us to listen to, it's breaking. So if you switch off your video and then speak, it'll be better.
You don't want to see the images? Because
I want to see the images again.
Switch off
your personal video.
Your video.
Your video.
We want to see the images.
You want me to switch off my video? Okay.
Yes,
correct.
Yes.
That was a recommendation by these people, and that probably is the reason that you're not getting 1 minute. Can I?
And we'd love to hear what
so I've done that already.
Was the loud noise.
Yeah, I know.
The video is switched off, sir.
I did that already.
Okay, fair enough.
Can you go ahead and show the slide after which the patient was intubated? After that, what did you do? So
the patient was intubated. We gave intracoronary drugs. We repositioned the TPI. We got a flow, and this is what we did thereafter. That we established the flow. The patient's rhythm was back. The STs were down, and we changed the wire to a Sion wire. I think we have missed some slides. 1 minute. Okay, no, this is not missed. This is fair enough. So yes. This is where we are. That this is the first IVL. This is C2 plus. We were able to give pulses here, and as we advanced, we could not go beyond this. You can see the severe indentation showing that there is a lot of difficulty, and with great difficulty, the 120 pulses that were delivered were given here. We took away this IVL, and there was still good flow, so we decided we'll take another C2 plus. And the second C2 plus, we started with distal inflation because I thought that once the profile is spoiled, we will not be able to come back. So we did give some distal pulses. Then we came back to the proximal part. And again, at this eccentric point, you will see that the IVL is not expanding at all. It was very difficult at this point to get the IVL inflated. And you can see that the buckling of the AL1 catheter because it was very difficult. This is the scenario after the IVL. There is still residual disease here. We did not have any other C2 plus 4.0 in the lab at that point of time. There was a 3.5. So we took a 3.5 and did IVL again at this point, hoping that we would be able to break this calcium. This did not work to my happiness. I was very reluctant at this point to post-dilate with a normal balloon because I thought that we will get a no flow and we were already in a problem and budget had been taken care of. So a fourth IVL was done. And after the fourth IVL, since there were no more IVLs, we decided to do imaging. So this is an IVUS catheter that has been pushed distally from this point to this point. The run is in front of you. I will request you to be patient so that you can see the images, since there was no distal imaging done pre-IVL. So as you can see, it is dense calcium. There are cracks available. There is eccentricity. It is deep calcium. There is nodules appearing, and there is multiple cracks. We will come to this third segment where you will see that there is a nodule, and it may take a couple of minutes, but it is of interest that we try to go through this IVUS run. So there are cracks here.
Yeah.
There's dense calcium here. There's no reverberations. The calcium is 180 degrees here. Again, it is dense calcium. Here, there's some cracks. Here, there is suggestion of a nodule. There's a flat plate here, which is not cracked. There are multiple cracks here. Again, cracks here. There's 270 degrees calcium. Here, there are multiple cracks. Again, you get this projection suggesting of a nodule. Probably this is the point where the lesion has not given way. It is almost 270 degrees. Here again, dense calcium appears to be probably a nodule. Here cracks again. Here more or less circumferential calcium. Here 180 degrees. Again, dense calcium. Again, something projecting into the lumen, probably nodular. And so the story continues. So we couldn't do a complete run. We could do only one run here. So we did another pullback from here to the ostium. Again, you can see it's a 360 degrees calcium. There's dense calcium. And at one point, you will see that just before it goes into the catheter, you will find a nodular lesion near the ostium or the proximal RCA.
Mm.
So this was a run. And therefore, I decided that we are not done. We took another C2, 4.0, and we gave all the pulses, 80 pulses, into this eccentric lesion, and we broke the calcium. Having done preparation, it was done, then post-dilated with the 4.0 NC, which was able to go, and it was not able to go prior to the IVLs. The first ever element stent is a 4.048 from this segment to this segment. It could not be descended despite this bed preparation. So we had to use a buddy wire with a choice PT, which has been pulled back prior to deployment. The result was good. Then the second stent, again, a 4.048. Again, you can see the buddy wire is in position, which was pulled back prior to deployment. This is the stent expansion, which expanded uniformly and very well at very low atmospheres, around 12 atmospheres. And this was a result of the third and second segment. We had seen that there was nodule, so we put another IVL here and generously gave all the pulses, 80 pulses at this nodule, and tried to push it a bit distally, but as you can see, the guiding is buckling. The result post-IVL was like this. I still felt the result was incomplete, so we used a 4.0 cutting balloon and cut it. This was the result. It didn't still look very good, but the procedure had become reasonably long, expensive. So we put a 4.5, 32 mm everolimus drug-eluting stent and deployed it at 16 atmospheres. The stent expanded beautifully. The stent expanded beautifully before you come to that. The stent expanded beautifully, but when I wanted to withdraw it, despite whatever I wanted to do, dilution, pullbacks, everything, it wouldn't come back. It was a nightmare. It was a nightmare that after such a lot of bed preparation is not coming back. So I decided that we'll pull the whole apparatus back because we have definitely stented and there's nothing much to do. and we pulled it back. We pulled out the guiding, the wire, and the shaft. And as you can see, we see the degree of distortion that had occurred. It was being pulled, it was just thin lumen, this had all got distorted, and any more pulling would have probably fractured the system. Anyway, we pulled out the system, we re-put in the guiding, we did a check angio, the system appeared to be good. I completed the procedure by post-dilating this segment with a 4.5, here with a 5.0, and here by a 5.5. And this is the pre and post images. This PLV PDA was not treated. Initially, there was the intent to treat it, but the procedure was long. This is the final result with the post-dilatations. So post-PCI, the ventilator was removed after 12 hours. Inotropes were tapered. He did get some degree of inotropes when he crashed, a small dose of noradrenaline. The IBP was removed on day 2. The vascular sites, the right femoral artery was closed with ProGlide. Post-end procedure, IBP after removal on day 2 was closed with ProGlide. He was mobilized and shifted to the room. Pre-discharge echo was 45% like before. The MR had reduced. There was no pericardial effusion. And the learning points are basically calcium is the enemy of the angioplaster. Calcium modification tools should be used aggressively to facilitate stent release expansion to ensure good long-term outcome. Calcium modifying tools add to the cost of PCI. The concept that orbital atherectomy does not cause no fluid flow is false. It does not exist. This is a misnomer. In reality, it is common, especially after high-speed atherectomy and depending on the lesion that you need to ablate. Loud noise during orbital means high calcium burden. It means you should advance even slower till the noise becomes less. No flow prevention drugs should be used generously. And I think in future, I would like to add these no flow drugs, like we add them into the Rota solution, into the Viper solution. And during that rest phase of 30 seconds, use the purge pose to release the drugs in the rest phase to prevent this problem. I have not done it till today after this case, but that is what I plan to do in future. TPI displacement in this case was catastrophic. The concept that you don't need a TPI is case-dependent basis. If you have a case which is extensive burden, right coronary, it is better to have a TPI in place. Despite having pre-decided to put the TPI in place, somehow it got displaced. Nobody noticed about it. Everybody was busy doing the procedure, including me. And this cost us some degree of CPR. Probably if it had been in position, this would have never happened. IVL is a costly device. Use of multiple numbers add to the cost. But if you don't do proper bed preparation, stent expansion will not occur. I forgot to mention that despite the bed preparations with IVL, orbital, and pre-dilatation with the 4.0, each stent required a buddy catheter, buddy wire, and removal of each balloon was difficult. And of course, the final one was, you saw what was the outcome. Stuck balloon after stent deployment is a nightmare. Every effort should be made to withdraw it without fracture. Dilute the contrast, keep inflator for a longer time, keep doing a gentle tug. Alternatively, you could pass an alternative wire and small balloon to free the spicule, but I think that was a difficult solution, so we just pulled back and we were lucky. Thank you very much.
All I can say is wow. but I do want to ask, how much dye did you use? The patient had a creatinine of 1.4 to start with.
So, sir, the dye that we used was Visipack, and we ended up using 250 ml of Visipack.
Okay.
There was no post-operative rise in the contrast because I did not mention the angio was done one day earlier. Since the expense was very high, the patient was taken off table to explain them the risk and the cost. And it's only after that I had explained that multiple tools will be needed and cost should not be a limitation factor for me. Then only I proceeded. So I'd given a budget of around 25 grand. We ended up with 25 grand, 6 IVLs, 1 orbital, 1 cutting balloon, multiple NC balloons, and a microcatheter. Yeah, it was a cumbersome procedure. It was already refused by a lot of people all over the country, and probably the main reason was that the mortality was told as very high. When the patient had come to me, the 2 questions that he asked his attendant was, what is the percentage death on table and what is the risk of death on 30 days? And
let me take it over. Interesting, very interesting. Well done, Dr. Gupta.
Thank you, sir.
Well thought, and of course your persistence to keep going for the bed preparation, which was a very good idea, and ultimately you were able to achieve all what you wanted, although it could have been probably a bit less number of IVLs balloons used, but because you were committed and you could not open the hole, then you had to go with a bigger size, which was. But the fascinating thing is that you continued to prepare the bed, and that was important. And obviously, before I go, I will of course ask you what was the percentage death you told patient. That would be my first question before you went.
So my answer to this from all my patients is that the figure is 0 to 100%. So either you die on table, and that is 100%, or you don't die. I never give a figure like 5%, 10%. That is for theoretical. I tell them that the risk is higher, but I explain them very clearly that if something goes catastrophic like it did, and the patient dies,
100%. I do agree with you.
100%.
It's a good
So
idea. It's a good idea. It's a good
so
idea.
it is always that it's either 0 or 100%. The rest of it is all nonsense.
No, I think it's probably we don't ourselves know what is the risk of death in such patients. It's a very complex procedure, and somebody who dies, the death is 100%, and somebody who doesn't die, the risk is 0%. But few things. One, of course, is that uh, despite multiple usage, you could not prepare the bed well. The only thing which I would have also liked to see, because you have spent so much of money, is a post-procedure imaging, which would have been a good idea to just show me what you got. But you did not leave it. And that is a good thing to understand. Your choice of guide catheter was good. It will give you the best support. You used two technologies at least, where the orbital combined with, and as I agree with you, there any device which is modulating the calcium, including IVL, can cause complication, perforation, dissection. I've had 4 dissections and 1 perforation, at least 2 perforation with IVL. So IVL is not without perforation, and there is evidence of that now, that IVL does lead to perforation. The only thing was that I was a bit concerned yanking the things out, because then the whole stent assembly could have come out. It caused a problem. But you were lucky that it did not break, number one, and you could manage. And the recommendation which you gave in the end should have been tried to put a balloon by the side and see if you can disengage this balloon which was caught into that spicule, which maybe was protruding in between the stent struts and the proximal segment. That was the most likely problem.
So I fully agree with you. The only reason I didn't do that is that I had around 50% of the balloon out into the aorta. The guiding catheter was very high. The balloon was a 4.5. It was impossible to cylinderize the guiding over the wire. And I was more fearful that when I put a wire, since I had let some overhang in the aorta, that I would go through the side. And since it had been post-dilated with a 4.5, around 20 atmospheres, including a pullback, which I showed you into the aorta, I thought that, I really felt that a little bit more would break away. I've had this experience, and I just pulled back everything, and I took the chance. I was not willing to risk distorting the stent at that point of time. It paid off. But yes, if you can
just to be the devil's advocate here. Sorry, please go ahead.
So I will give the chance, Dr. Agarwal, just 1 second. I'll I'll ask comments and also Dr. Bansal's comment. Is that sometime all of us have gone into a territory of trying to do something which is not allowed to be done, or what is not recommended to be done. Most of the time we get away. Most of the time we get away. But sometimes we don't get away. Then we repent that why did we not choose this? But what ends well is well. So that is the final understanding. Whatever you do, if your procedure is ultimately done well and the patient is coming out of the table without any serious complications, life-threatening complication, you have done well. But then just for the teaching purpose, it could have been a good idea to try to just push a balloon, manipulate, and ultimately you have to take a risk sometime to pull things out, which you did. Unfortunately, you were lucky that it didn't happen. That was one. But let me invite Dr. Agarwal and Dr. Bansal to give their comments, and then we'll move on quickly. Half-minute comments, please. Thank you. Go ahead.
No, I was just wondering, I mean, hats off to you for the persistence and realizing that, you have to prepare the bed so well and do whatever it takes. So that is great. And you use multiple IVL balloons and multiple runs of IVL. I just wondering that could the orbital also have been tried again, after you had cracked a bit of the calcium. I know it needs a change of the wire again, but maybe that technology should not have been abandoned with the initial, you got a loud noise and you said this case is not for IVL, for orbital. But could we have tried it again after the initial IVL?
So thank you for your comments. There's a misunderstanding. Bed preparation was orbital was done till the end of the third segment, despite the loud noise. It's only after persistent burring there with as much time as we could that we got the catastrophic no reflow, and we needed to change. Now the no reflow was so catastrophic, you cannot imagine, in the lab, that we needed to intubate, put the TPI back, that I did not want to do any ballooning. I wanted to go the simplest way. That was the reason we did IVLs. And post IVL, I did not want to take the risk of again doing a reorbital, that if we have another reflow, probably he will not tolerate it. So my aim was that I have done orbital with 80,000 from first part of RCA till the distal, where I wanted to do. And then I've done high speed orbital also from that segment too. Probably if there was no reflow, I would have done a few more runs, but I did do adequate amount of orbital there, 3 to 4 runs, maybe 1 of 30 seconds and 2 or 3 of 10 seconds, but it was done as much as possible that was feasible. The only thing that I was not able to do in the procedure which I had planned was to do a retrograde orbital at the ostium on the final procedure, but the patient collapsed. It was catastrophic. We had to remove the hardware, and I repented that when the catheter could not be pulled out. Had I been able to do a retrograde orbital, because antegrade would have never worked, probably that that thing that got stuck would have not happened. Probably the orbital would have broken it, and the IVL and the cutting balloon would have refined it. So that is my only regret. But orbital was done adequately. We had 9 runs of 80,000. So you can calculate the time, and 9 runs of 120,000. So it's 18 runs. That is in my personal opinion, that is adequate. And I didn't have the courage to do it after IVL. My aim was to get the patient home.
And without your initial orbital, probably the IVL may not have gone, because
so yes, after the orbital, you saw that the IVLs were not going, and they were dog boning.
It did not go in. So
I think it was the spicule. It was the spicule which was protruding, and as you said correctly, the retrograde would have shaved it out, because the direction of that spicule was only forward. The retrograde would have helped you.